So thank you, Laura, for the introduction. So yes, I'm a speech and language therapist, and I support children with language and learning needs. Like PS, I have a fun fact. 10% of all children across the population struggle with their language needs to an extent that requires specialist intervention, and it's often an unknown area because these children use other ways of masking these behaviours. So they might present with behavioural difficulties or other emotional difficulties, but the underlying cause is a language and learning need. And those are the children that I support. I've been doing that for 15 years now within the NHS. And in June last year, I was awarded a fellowship by the National Institute of Health Research, which is the research arm of the NHS. And they are funding me to carry out what is effectively a clinical PhD. So it's all elements of a PhD, but a strong clinical aspect. So whilst I'm doing my PhD, I'm also doing lots of clinical development, clinical supervision, consultation work. So it's very practical, which suits me fine. And the area that I chose was digital therapy. So looking at the potential to translate day-to-day therapy, which is very much still pen and paper. So a lot of it's behavioural therapy, and we write down and we draw and we demonstrate through pen and paper, take a photocopy, give it to the child, who then the parent, who then give a copy to school. So you can just imagine the paper trail and how much is lost and how much is kept, and looking at if we can digitize that and also give some ownership to the children and young people so that they can manipulate their own therapy. And the core principle of my project is co-design. So really thinking about working with the children with language disorder to create tools to support children with language disorder and to involve stakeholders ranging from parents, health professionals, educators, psychologists. So really thinking about the whole co-design process. And I'm funded by the NIHR, and I'm based at St George's Trust, which is in southwest London. And for the academic portion, I am based at City University of London, and I'm also due to start a fellowship within a fellowship at the Alan Turing Institute, which I'm very, very excited about, because that really hopefully gives me that data science technology validation from me coming as very much a clinician. So that's kind of a bit about me. When I started my fellowship, so a year and a half ago, one thing I became very quickly aware of was that there were very few like me. So very few females in tech from a BAME background who were coming from a clinical angle and working in the realm of inclusion and accessibility. And really that's what drew me to the Shuri Network. So the Shuri Network is the first NHS and care network for women of colour in digital health and their allies. And I think the allies aspect is really, really important, because the responsibility for inclusive health lies with all clinicians. We have a duty to support accessibility for all patients. So this duty of inclusivity lies with all as well, anyone who is clinical and also non-clinical within the NHS. And so I really like that model, and I've been drawn to that model, and I'm part of the steering group for the Shuri Network, as is Ijeoma. And I think that's really what I wanted to focus on today, of kind of why it's so, so important to really consider inclusion and diversity when thinking about tech. And obviously my area is health tech, and thinking about it at all areas of planning. So right from the planning to the trialing to the implementation to the evaluation, all aspects need to have an inclusive approach. And so what I wanted to do was take an example, which I hope is a very relevant example, and talk through it almost as a worked example of why it's so important to be inclusive and what can go wrong when it's not. So Laura, if you could go to the next slide, please. So the example I've chosen is thinking about the COVID-19 track and trace plan. And this is not my area of specialism at all, but I'm approaching this as a clinician working in health tech from a BAME background. So the data that I'm presenting is based on what I've come across from media, from anecdotally, so speaking to peers, but also from the research. And I think that's important because what I'm bringing is my lived experience. But it's also a caveat of if some of this is not quite accurate, up to date, that's the reason why. It's not that this is an area of specialism, but this is an area that I felt was a story where I looked at this and I thought, what's lacking is this approach of inclusion and diversity. So hopefully everyone's aware of the fact that this COVID track and trace plan, I just realised the year is wrong, so it wasn't last year, it was this year. In May 2020, it was launched on the Isle of Wight, and the assumption was that Isle of Wight would be where the app is trialled, made as good as it can be, any kind of issues are tweaked out, and then it's kind of rolled out nationwide across the population. So it's very much thinking about trialing it, tweaking it, improving it, and then off it goes. And there's a practical rationale for choosing Isle of Wight specifically, and that's because it has a single NHS trust that covers all NHS services. So it is measurable, you know, the data is clean and clear, and you can follow the path through. So that was the rationale behind that. Next slide, please, Laura. However, what was not considered was what I would argue was the service user's journey. So thinking about patients and which patients would require this most urgently, because who are more at risk. And the information was there. So the study that I put up here is linked to the pandemic from 2009-2010, the Berkeley Pandemic. And the data showed that people from non-white ethnic groups in England were 84% more likely to die, basically. So the mortality risk was 84% higher compared to white populations. And in their study, they actually put recommendations. So I'm just going to read the recommendations. So they said, these results highlight the importance of rapid identification of groups at higher risk of severe disease in the early stages of future pandemics, to enable the implementation of optimal prevention and control measures for vulnerable populations. So the information was there, the advice was there, but it was overseen. And if you look at the demographics of the area that was chosen to trial the app, I mean, the numbers speak for themselves. So there was not a significant BAME representation. And eventually it was rolled out, the trial in Newham. So it was rolled out in August in Newham, but it wasn't rolled out because there was a higher risk factor. It was rolled out because the reality was there was a greater number of deaths there. So rather than it being a preventative approach, it ended up being a reflective approach in terms of, okay, the deaths are higher, this is where we now need to trial. Next slide, please. So I guess, so that hopefully I try to choose an example that most people can relate to. But I think for me, the learning from that was that if there were people involved from the very, very early stages who had that lived experience, it would have become apparent from an earlier level that actually Isle of Wight may not be the most appropriate starting point, or alongside Isle of Wight, we need somewhere that has more of a mixed demographic. So there was that rationale for choosing Isle of Wight in terms of processes and being able to, it's manageable and it's clean because of one NHS trust. But what wasn't considered was this inclusive design and inclusive consideration of how are the end users going to be impacted and who's going to be impacted more or less. And so from my perspective, I would definitely say that in order to address the need of all, and that was the goal of this track and trace kind of trial, you have to have inclusive, diverse process from the start. And if you don't do that, then that leads to bias and inequalities, which can lead to really significant severe consequences for health and well-being. But if you flip that and you use an approach that is inclusive, you reap greater benefits for all. And that should be a priority for all of us, not just from the perspective of a moral perspective, but even thinking about an economical perspective or greater health of the country as a whole, or even from a social perspective. I think if you take an inclusive design, we all benefit from it. But if you don't take an inclusive design, then you are putting certain populations at risk. So that's kind of my view, and I hope I've kind of justified where that's come from and why it's so important. Next slide, please. And yeah, so that's it. So there's my details, and on Twitter, so the first Twitter handle is my name, and then the second is my project. And if anyone is interested in kind of co-design with populations that require support with accessibility or learning needs, please do contact me, or any questions about the Shuri Network, which I know Ijeoma is going to cover as well. Thank you.
Thank you. Thank you very much. Okay. Floor to you, Ijeoma.
Hi, thank you very much. I think the only thing I'd ask is if you can let me know when I have about 2 minutes left, just to make sure I stay on time. Thank you. And I think to pick up from where Rafiah left off is, my background is also very much coming from the clinical standpoint and shifting into technology. But what I'm really bringing in is also that perspective of considering technology alongside the way we consider people in healthcare, and really that flip perspective of starting with care as the core process to uphold in digital product and service development. And so the idea is that really there's lots of different dimensions to look at, but if what you're starting is how do we provide care, how is care going to be enacted and practiced, and what is the outcome that we want of good care, then it brings us to a place of deliberate design in healthcare, which I think is helpful. Thinking about what socially responsible AI and social impact, I'm going to leave the AI topic alone because I think we're not quite there. There's a lot of nuance and context that is not quite within the data that we have or the data that we're collecting. And so what we need to do is be deliberate rather than urgent per se. In this study that I'll talk about, looking at wearables and sensors in Internet of Things in healthcare, it's looking at how technology more broadly shifts the communications in healthcare. It reshapes relationships to self and healthcare professionals. And it also, has an impact on what we're going to do into the future. So some of the things around this particular study, which I completed for my public health dissertation, started with the signal of the Apple Watch 4 in 2018. This was released into the consumer market, and it was a product that had medical grade monitoring of the heart rate. It was smaller, faster than most of the things that were already available, and it was outside of the health sphere. And so in this study, I spoke to 16 experts across the US, the UK, and Northern Europe who worked across the disciplines of technology, business, innovation, social sciences, really to understand that this device and others like it was part of an enabling technology to shift care outside the traditional hospital and clinic. It's going into care settings, it's going into the home, and it's going to people with lots of long-term conditions. One of the implications of that is that this communication order makes all information available to all parties at once through the device, including patients, whereas a lot of times that was brokered through clinicians. When we think about the reshaping relationships, it almost pushes healthcare professionals to be always on and presumes that healthcare professionals are always on because there's an assumption that healthcare professionals are brokering all of this information. Have you done enough steps? What does it matter if I didn't wear my device and it didn't count my steps? But it also, this process that was supposed to remove the healthcare professional and that medical expertise actually shifted some of that mediation more to healthcare professionals. And I think one of the notable things was around the future considerations is that these wearable sensor devices had this implication of being arbitrated what is good health, or more specifically, what might be good performance of health rather than bad. And considering the person or the patient wearing it to be increasingly unreliable in communicating their health. So in reshifting relationships to professionals, one of the things that was notable is that the first line of contact that was being shifted. Clinicians have to now deal with a tech company or device or something else that's maybe telling patients and people what's going well, what's not going well, and it's not directly connected to the clinician. When I speak to teams working in healthcare and design innovation, there's a concern that the relationship the clinician has is going to be diminished because there's another place that patients can go to track their symptoms and see how that's going on. And thinking about reshaping the relationships to self, there's this idea that everything is going to be interacted. One of the quotes talked about, it'd be great if this thing is coming into use and says, my blood sugar is too high, so I'm going to send a message to my fridge to tell me what it's got in it so that I know whether or not I can eat it, or in some cases, whether or not the fridge should lock itself. Then thinking more about shaping that relationship to self is things becoming increasingly implantable, looking at genomics, and becoming increasingly more invasive, but not really appreciated that way because they're smaller. They work without the person needing to interact with them at all. And so I think that, thinking about the keynotes from some of this cross-disciplinary exercise was showing, I think, the value of this qualitative approach and also this socio-technical approach where people are shaping technology and technology shaping people, but I think really highlighting that focus on humans. The signals that were noticed out there is, what is care, where is care, and who's responsible. Another signal is this multi-sensor fusion that's replicating and approximating physiologic functions and biometric parameters. I think if you look at it now, there's this accelerant of the pandemic and some of the processes that have been talked by my fellow speakers around remote working, remote monitoring, and remote provision of health. I think we see tech devices become situated in this clinical dynamic without the deliberate consideration for the person, the professional, and the interaction of the person and the professional in healthcare. The therapeutic alliance is relational. And so I think in the development of products and services, again, each of the parties needs to be considered as well as that interaction. So what the questions I would have is, thinking about things being deliberate rather than urgent, leading with people, context, and principles. The question I would leave the audience with is, how do we cultivate socially responsible digital products in an emerging low-touch world? I would think about the principle of digital literacy and access to social determinants of health, in addition to our traditional constructs of the social determinants of health. And how do we navigate this transition that's being accelerated by the pandemic and some of the innovations that are out there, medicine and healthcare, for some of the ways in which it doesn't function properly, has a focus on care as its principle. And I would say that that should be one of the things that's upheld as a starting point. Thank you.